The brain tumors as a whole make up the most common solid tumors in children. The most common malignancy, we said, were the leukemias, but the most common of the solid tumors are going to be the brain tumors. And that's if you take all the different types of brain tumors. The mortality with brain tumors is about 45% and also has a very high morbidity. Remember that brain tumors, even though they may be benign histologically, they're in the brain. And so consequently, getting to them can be a problem. You may not be able to get them out completely, or just their location means that you can't get them out at all, and so they have a much higher mortality. Most brain tumors in children are seen under 7 years of age, and most of them are infratentorial. And the symptoms of brain tumors depend on the location. So sometimes a brain tumor, if it's located, let's say, in a temporal lobe or somewhere other than the midline, the patient may present with a focal seizure. Brain tumors that are in the midline and obstruct flow of cerebrospinal fluid may present with progressive signs of increased intracranial pressure. So the location, again, determines the presentation. The best initial test for diagnosing a brain tumor, if you suspect it, is a head CT. It's going to show you a mass, and it'll show you the location. So it's doubtful that they'll ask you that as the next test, because you're going to want to get a CT scan for all of them. You can't say that this is one type of tumor versus another type of brain tumor without getting a CT scan. You just need to look at the location. But that is a great test to use for diagnosing what's going on inside the brain. Here we have subdivided location and age and type. So less than 1 year of age, most commonly you're going to find supratentorial tumors, and these will include the choroid plexus tumors and teratomas. When you're 2 to 10 years of age, then we start thinking of infratentorial tumors. And since we said that most tumors are under 7 years of age, most brain tumors are actually infratentorial tumors. And these include the juvenile pilocytic astrocytoma and the medulloblastoma, although the medulloblastoma tends to be a little bit supratentorial. Greater than 10 years of age, most brain tumors are going to be supratentorial, and we worry about the astrocytoma. Of all of the brain tumors, actually, the astrocytoma is the most common. We're going to go through various types, remembering that you're going to obtain a CT scan for all of these. The astrocytoma is the most common of the brain tumors, and most of them will be infratentorial. They are rarely invasive, so you get to them, you have a pretty good prognosis if you can get the whole tumor out. The most common of them is the juvenile pilocytic astrocytoma, and the most common site will be the cerebellum. These patients require surgery and then radiation and or chemotherapy. Signs and symptoms, again, if it's in the midline and it's starting to block CSF flow, remember these patients may have, in the morning they wake up and they vomit, and then they're fine. And that's because when they're laying down, any tumor that's sitting in the blocking flow of cerebrospinal fluid may be just hanging in there. When they stand up, now the fluid flows freely and there's no increase in intracranial pressure now. It's relieved, and they feel better throughout the rest of the day. Next morning, it happens again. At some point, the tumor will be big enough that it obstructs flow of the cerebrospinal fluid, whether they're laying down or sitting up. It won't matter then, and then they'll have more persistent vomiting. The malignant astrocytoma, it can be diffuse, and under malignant astrocytoma, we have the glioblastoma multiforme, which has a poor outcome. Here, the arrow is pointing at that large blue area, and that's an astrocytoma. Embryonal tumors include the medulloblastoma. This is the second most common of the brain tumors. It's more common in males around 5 to 7 years of age, and it's usually midline, cerebellar, and so these patients will present sometimes with a wide space gait or with ataxia. I remember a 4-year-old telling me, walking in with wide space gait, and he kept complaining of pain in the back of his neck. He said it felt like he had a gob of steel there. He also had papilledema on visualization of the fundus, and that shows you that there's increased intracranial pressure. It will be in the posterior fossa. If it blocks the fourth ventricle, it will cause hydrocephalus. And then, again, you can have the vomiting or you can have increased intracranial pressure. The brainstem tumors, these are very difficult to deal with because being in the brainstem, they're very difficult to remove because of all the vital structures that comprise the brainstem, like breathing centers. These patients can have motor weakness, cranial nerve deficits, and they can also have cerebellar deficits. So look for ataxia. Again, the best test is to go ahead and get a CT scan. These have a very poor outcome. One reason, again, is because of just the location. The ependymal tumors, think of the ependymoma. Most of these are in the posterior fossa, and they are the ependymal lining of the ventricular system. They are generally non-invasive, and again, surgery is the way to go with these. Supratentorial tumors, the most common one, and the one you're going to have to really know for the exam, is the craniopharyngioma. And we discussed that as a cause of short stature. Look for a patient with short stature who is probably also having visual disturbances. You should think about a craniopharyngioma. These are suprasellar tumors. An X-ray can show a calcification in a large sella turcica, but the best test next to, is to go ahead and get the CT scan, and it shows you the tumor. Remember that once you remove the tumor, you have to replace hormones because you've basically removed the pituitary. So a cause of hypopituitarism is going to be a craniopharyngioma. Optic nerve gliomas. This is the most frequent tumor of the optic nerve. Remember that there's an increased risk of this with neurofibromatosis. Patients will have vision loss on one side because it usually just affects the one nerve. They can have proptosis. The eye is basically bulging out. They can have deviation of the eye, nystagmus, and certainly you can see strabismus in these patients. So you do worry with some patients with strabismus that they may be having a tumor causing this. And again, remember the association with neurofibromatosis. Now, some of these tumors, especially patients with neurofibromatosis who are diagnosed with optic nerve gliomas, initial treatment is basically observation. You try not to do anything for it. However, you do have surgery once you're starting to have visual problems.